truly honored to be invited in this conference. Thank you, Colin. Thank you, Kath. Thank you, Helena, as well. I am an ENT surgeon, so please don't ask any clever questions. I mainly work with airways, adult airways. I have a vast experience in other metabolic diseases. They behave similar to Costello. They are quite rare as well. And that's how I got involved in working with Petra, who spoke earlier. She's left now. I work with a team of cardiologists, anesthetists, metabolic medicine, clinical engineering. I offer airway support to different hospitals in the UK, abroad. I'm part of the national guidelines for complex airway and metabolic airway diseases as well. I'm part of the Airway MDT in Salford, which is the regional center for most of the metabolic airway diseases. I'm also part of the National Cardiac NPS MDT, which was previously run by Petra. And I get invited like this in other conferences as well. So let's start with the scenario. We have an adult patient who has got Costello Syndrome. This patient has numerous medical problems. She's being planned for an anesthetic procedure. So that's when I get involved into this. I've been asked by Petra to see one of these patients. The family are unsure, is this the right procedure to do? Is this very risky? Is this beneficial? We don't know. The clinicians are also not very sure. The cardiologists, they're not very sure what's happening here. Let's get some more people involved. So the big questions that we want to ask is, are there any risks of intervention? If so, how risky is this going to be? How can we perform the procedure safely? And should we really be performing this procedure in the first place? So we'll keep the scenario aside. We'll talk about Costello. It's very likely that you all know more than me about Costello. So I'll not go too much on this slide. So it's an autosomal dominant disease due to HRAS mutation. Multiple organs are involved. There's growth delay. Just now heard to talk about that. There's developmental delay, intellectual disability. They have some characteristic facial appearance, hyperextensile nature, cardiac issues, craniofacial abnormalities. There's increased chance of developing certain cancers as well. So the big question I ask myself is, do Costello have an airway issue? So let's keep the name aside and let's look at the body structure itself. Multiple systems are involved in this complex rare disease. Predominantly craniofacial abnormalities, spine and skeletal abnormalities, and this is the region of the airways. It's very rare. Often it says that prevalence is less than 1 in 1 million, and according to some of your websites, the incidence is actually 1 in 3 lakhs, and there are about 300 to 600 people, that's all, in the entire world. So it's quite rare. So we don't know much about this syndrome, let's be honest about it, especially about airways. And when I looked at the literature, there's not much written about airways. So let us look at similar diseases like this, which I deal with, which are also lysosomal storage disorders. They have multiple system diseases, they have cognitive issues, they have skeletal abnormalities, they have rib cage problems, they have liver and spleen issues, joints, coarse skin, cardiac issues, eye problems. So this goes somewhat like, this probably, this is also a multi-system disease like what we are dealing here with Costello. So these are the 3 main diseases which affect the airways. Mucopolysaccharidosis, mucolipidosis, and alpha-mannosidosis. And this is something that, Salford being the regional center, I see quite a lot of these patients. And there are only 200 of these patients in the UK. So somebody did a very good paper published in 2022 which looked at the anesthetic complications of of patients with metabolic disease, you can see every possible complication has been mentioned here. They could not ventilate, they could not intubate. Some of them had tracheostomy. There was pulmonary edema, airway edema, and more dangerous is they had to do the procedure blindly. They did not know where they were going. They just ran the tube somewhere, expecting it's going to work. The common methods of ventilation were not working. Patients' oxygen levels were dropping down very rapidly. Lots of secretions. CECO is cannot intubate, cannot oxygenate situation. That is almost life-threatening. So there is something very dangerous with these complex multi-system metabolic disorders. So let's look at what does the literature say about Costello. So this is a good paper which reports only 4 patients, but it did a literature review of about 56 patients. In the neonatal period, 78% had respiratory complications. There was transient respiratory distress in about 45%. 62% had upper or lower respiratory tract problems. There was upper airway obstruction, so that's very concerning. There were also airway abnormalities.
Sorry.
It's okay. Macroglossia, which is huge tongue, which is very big tongue. Lots of redundant tissue in the airway. Laryngomalacia, vocal cord paralysis. Now every abnormality that you can think of has been reported in this paper. And then there's another paper which looked at a case report and then reviewed 5 more patients, which looked at the lung parenchyma. They found lots of opacities in the lung, atypical collagen, atypical elastic fibers. And when they looked at the x-rays, they found lots of shadow, lots of, you can actually see there, these are the shadow areas inside the lung, and then lots of opacity, ground glass opacity in the lung. So there is definitely something not right here with these airways. So what can an airway surgeon do, apart from coming to conferences and having a big lunch? We have some more help. We can assess the airway. We can look at the entire airway from lips to lungs, like how we do for other complex metabolic airway patients. We can provide a holistic approach to the care of the patients. We can help in decision making, which is necessary for airway intervention. Now, this patient of ours who may need a surgical intervention or may not need a surgical intervention, we can actually tell, look, is this going to be risky or not? We can plan an airway intervention if you have to safely intubate and extubate. We can be part of the MDT discussion to safely manage intervention, and my colleagues were recently involved with that. So, how do we do this patient? So, it's a very intense procedure. We take a very detailed history. We examine the patient. We like to do everything non-invasive. So, after we examine the patient, we pass a little camera which goes through the nose, and then it goes into the throat. And that's the only invasive part of the entire procedure. Then we request some CT scans. Now, if possible, we'd like to do some lung functions. And then comes the fun bit, which I'll tell you. So, this is the nasendoscope. It's not very difficult. Those people who have had it, they'll probably budge on it. It's not that difficult. It's like a little wire which goes through the nose. It takes less than a minute to do it. Makes your eyes water. And we can take lots of pictures with that. And these are the pictures. This is one of my metabolic patients. You can take pictures of the airway, you can do lots of calculations, look how crowded the airway is. You can go inside and then look into the voice box, into the larynx, and you can actually see how bulky these airways are. That will give us an idea as to what's happening. Patients don't even need anesthetic for this. It takes less than a minute to do it. So then we do a preoperative workup. We do a CT scan, which the patient has to lie down in the couch for some time. And then we try and deal it like a mathematical problem. We take lots of measurements of every single aspect of the airway, right from the lips to lungs. So lots of dimensions. Look how this airway is, what's the caliber of the airway? Where is it bent? Where is it turned? We take lung functions if possible. Now we understand that some patients who have got learning difficulties or who cannot tolerate, they cannot do lung functions. That's fine, we don't manage to do that. But we can actually do some morphometric analysis. We can look at the rib cage, we can look at the dimensions of the lungs and the body volume. We can check the voice. These give you a rough indication of how good the lungs are functioning. So this will tell us if this patient is going to tolerate anesthesia or not. So we need more than this, Unfortunately, it doesn't end here. So we need something more. And often I'm asked this question, oh my God, this guy he's always into something, why do you need this? This is working now, so you don't need anything more. Yes, we need something more, because traditional methods and traditional ideas sometimes don't work. We want to make the existing methods work better. It's a complex problem, it's a rare disease. We don't know much about it, so we need something more to know about it. And sometimes, like COVID, we need to understand this better. So we come up with this idea. We do a 3D planning of the airway. We take a difficult airway, we take the CT scans, we create a 3D dimensional model of the airway. And mind you, this patient has gone home already. Okay, the patient is not in contact with us anymore. Then we create a cloud model and we share it between our colleagues. We print the 3D airway and then we do a virtual endoscopy, which is actually going into the airway like an aeroplane and then looking all inside the airway and trying to understand every single bit of abnormality, what's happening in the airway. In some situations, we also use a virtual reality. We put on VR goggles, look into the airway and see what's happening. We create little models of the airway so that we can practice intubation and see if it's really possible or not. And finally, if this patient needs to be intubated, then we create some models which can be used for the intervention. So imagine you buy a car. You buy a car. Somebody has actually tested it. Somebody has taken it, hit it in the front, hit it on the side, hit it from behind, rolled it over, and then they have sold it to you. Right? It's such a shame, we don't do this in medicine. We just go there, let's take this patient to the theatre. Let's put him to sleep. Let's see what happens. I've done this lots of times. I'm very experienced. It's such a shame we don't do it. But in complex airways, this is what we really need to do. We need to simulate so that we reduce our risk. And this is how we do it. We build an entire airway on a 3D printer. We understand the problems. We crash test it. We devise methods to overcome the problems. We trial it. And then we use this in our consultations. So this is one of my patients who has got a very complex airway. You can actually see this patient has got a very large skull. And the airway is quite bent. It's quite twisted and turned in every single direction. So we calculated mathematically where it is bent, how much it is bent, and what's the size of the tube I can use, how do I bend it, how do I negotiate through these little corners to go into the airway. And then we cut the airway into half. We chop the airway into other half. We measure all the dimensions, and this can be done without even seeing the patient. This can be done remotely. We print the airways. These are all the airways of some of my patients who have had similar metabolic disease. And then this is the fun bit, the virtual reality. You can actually wear some goggles. And this was devised by my colleagues, Stuart and Praveen. Go there, take off the skin. It's not important. Go closer, look around. You can see the abnormalities of the spine if there's anything. Take off the rib cage, it's not important. Take off the lungs, that's not important. Then you can look at the windpipe, the trachea. You can go inside the trachea, peep inside, see what's happening. Oh, by the way, there's no heart here, that's not important either. Don't tell that to Petra. Then you can go inside the rib cage, you can actually see how bent this trachea is. How is this getting angulated? So that you can actually see what abnormalities are going on with this patient. So this is another. You can actually also interact with the airway. You can hold the airway in your hand. I can turn it around. I can play it. I can take it inside my face and then I can actually look inside and know exactly where it is bent, what's happening. I can see in various directions. You can see that that's how bent it is. It's not a straight airway. So this is virtual endoscopy. You're actually flying inside the airway like an aeroplane. You're going inside the airway all through. You can go all the way to the bottom. You can actually see where it is bending and what's happening. And we finally print a 3D model of the airway. And then here I am on the right side, I'm testing the 3D model. And then I'm trying to see, can I really put this patient to safely put this patient to sleep or not? And here I'm able to do that. And that patient eventually had a cardiac surgery later on. And that's how you got the airway back in. So you want to know how risk-proof this procedure is. So we devised this little calculator. It's available online. You enter all the details, all the airway parameters that you can get it by examination. It's a 15-point question. And then you calculate a score. It gives you a score of 27 out of 45. That's a very, very high score, and it will tell you which parts of the intubation are going to be difficult. So this is how you can actually calculate how risky this procedure is going to be. And then finally we create a passport. We write the entire things on a sheet of paper, put everything, and then all the simulations, and then give it to the patients. So that tomorrow, if this patient has gone on a holiday somewhere, say to Scarborough or to Dublin, wherever, and God forbid if they end up needing some healthcare, they can take this passport, they can show it to the local doctor, they can understand what's happening, and then they can plan. And it gives out all the guidelines according to the Difficult Airway Society of the UK, and any doctor anywhere can understand this. So we'll go back to our scenario of our patient. So we did exactly the same thing. We did a nasentoscopy, made all the measurements, looked at her airway. Then we did some 3D reconstruction. We found out quite a lot of problems. And we found that the airway was quite bent. There were quite a lot of airway abnormalities in that. We measured all the angles. We chopped the airway into half, looked at all the dimensions. Then we did a virtual endoscopy. So this is me flying into the airway again. As you can see, it's a very, very twisted airway. And if I have to put a tube into this, I have to negotiate through quite a lot of sharp bends through this, and it's not going to be easy. So I go down first, the red dot on the right side you can see there. Then I have to take a horizontal turn, and then I go down further to reach the lungs. So that's a very tortuous pathway for me to enter into to make sure the oxygen goes into the lungs. So we discussed lots of potential airway problems with this patient. We gave a final score of 20 out of 39. It's very high. It's extremely high. So that's going to be quite dangerous. And we predicted the difficulties of oxygenation. Every step is going to be difficult in this patient. The intubation, all possible airway maneuvers, front of neck, cardiorespiratory, everything is going to be difficult. So in this way, we did a risk assessment. Then we finally did the crash test. So we took the airway, So that is a 3D reconstructed airway. We printed her entire airway. And we tested different tubes. And we thought which tube might work. And we put a tube into that. It does not go. It does not go without damaging the windpipe. It does not go. So then we printed the entire airway, and then we tested it on a model. This was tested by about 4 people. All the 4 of us failed. So in this way, we told ourselves, look, let us be pragmatic. This is not a situation that we can actually come out safely. So in summary, Costello Syndrome is also a multisystem disease. Airway is determined by many systems: the cervical spine, the upper airway, the chest, lungs. So upper airway may be affected in Costello, especially in severe phenotype, but we need more studies. We need more patients to understand this. Assessment should be holistic, from lips to lungs, by non-invasive methods like how we have done. It causes least trauma to the patients and to the family. Risk quantification, carefully weighing the benefits and risks, are very important. It's very important to know the risks. It's likely that any intervention we do will cause more harm than benefit. Decision is by a multidisciplinary approach, including the family. I'm happy to take any questions. Thank you.